the following slides. The optic nerve meninges is continuous with the brain meninges. So any increase in the intracranial pressure will be transmitted onto the optic nerve head. And any condition that causes the stasis of the axoplasmic flow will give rise to optic disc edema. So, disc edema secondary to the increased intracranial pressure is papilledema, and other acquired edematous disc is disc edema. So why is disc edema important? Disc edema is important because it causes ischemia of the optic nerve head, which eventually causes visual impairment. And papilledema has diagnostic as well as therapeutic potential. So how will you diagnose pseudo disc edema first? So this is a 22-year-old girl presented to us with a headache, and vision was 6/6, N6 in both eyes. The right eye was normal. Look, this is a fundus picture. Right eye was normal, and the left eye showed disc elevation with blurred disc margins. We did the fundus autofluorescence, and that picked up the disc drusen. We also did the B scan, which confirmed our diagnosis of disc drusen. This is a 60-year-old female who came to us for a routine checkup, and we did a multicolor fundus photograph, which showed a disc elevation in the left eye, and this is the OCT of the left eye, which shows a classical lumpy, bumpy appearance of the OCT, which is suggestive of an optic nerve head drusen. So now, how will you differentiate between optic nerve head drusen and disc edema in OCT? See, in OCT, if you are able to see a hyper reflective globular space in OCT, that is suggestive of disc drusen. And if you are able to see a hyper reflective triangular space, then we can take it as disc edema. We can also diagnose optic disc drusen in CT scan, but we usually don't do it. Now, what is this? Bilateral blurring of disc margins. This is a 5-year-old child who came to us for a routine checkup, and her refraction was +6 dioptric sphere both eyes, and improved to 6/6. So this is a hypermetropic disc, which is again a pseudo disc, DD of pseudo disc edema. So what are the other DDs of pseudo disc edema? It could be myelinated nerve fibers and hyaloid remnants, which we can find out by ordinary fundus examination itself. So pseudo disc edema often presents to us in a routine, we can see in a routine examination in an asymptomatic patient with marked hypermetropia or myopic astigmatism. And when we check the past medical records, we'll be able to find it. Now, how will you diagnose true disc edema? What is this? And what is this? How will you differentiate between true disc edema and pseudo disc edema? And what is this? Are you able to see a small globular, yellowish color globular thing in this disc? If you are able to see this globular structure, you can very well say it is a optic disc drusen. Whereas, if you are able to see this arbitration of vessel margins and disc hemorrhages, RNF elevation, hyperemia of the disc, and dilatation of the nerve, vessels, then we can say it is a true disc edema. So these are the differences between the pseudo and true disc edema. So in a true disc edema, patients present with headache with or without nausea and vomiting, with a new onset headache, which is worse in the morning, worse on coughing and sneezing, and with transient obscuration of vision, pulsatile tinnitus, horizontal diplopia, vision may be reduced or normal. Now, coming to the causes of bilateral disc edema other than papilledema, the important causes are malignant hypertension, diabetic papillopathy, optic nerve sheath perineuritis, usually because of tuberculosis, syphilis, etc., and renal failure and hypocalcemia. This is a 43-year-old man presented to us with severe headache. BP was 220, 120, and best corrected visual acuity was 669 N6 in both eyes. He had recurrent disc edema. And first episode was in 2016, and second episode was in 2018. And he was diagnosed to have bilateral disc edema due to malignant hypertension. Now, what are the causes of disc edema due to raised intracranial pressure? There are three important causes are there. One is because of space occupying lesion, second is dural venous sinus thrombosis, and third is pseudo tumor cerebri. This patient is a 67-year-old gentleman who came with headache, vomiting, and left-sided weakness 1 week duration. This is the fundus picture, bilateral disc edema again. When the MRI was done, the MRI flared image showed a mass lesion here, surrounded by this white color edema, and here you can see the ventricle. In this side, the ventricle is masked by the edema, and the papilledema was because of this surrounding edema, and this is the post. This is a mass lesion. This is a MRI showing the mass lesion. This is again the picture of the same patient, post-contrast images showing the space occupying lesion. This is another 28-year-old obese lady with polycystic ovarian syndrome, and she had recent onset headache and nausea, and the fundus picture was this, bilateral disc edema. And the MRI showed the arrow depicts the transverse sinus thrombosis. MR venogram was done. Here the transverse sinus is absent because of the thrombosis. So dural venous sinus thrombosis can occur in any age, male or female, and it can usually occur after infectious mastocytitis, dehydration, and pregnancy. A 35-year-old lady classically presented with throbbing headache, unremitting, and was accompanied by nausea. She had occasional tinnitus as well. Best corrected visual acuity was 69 N6 OU. This was the fundus picture. It was a florid bilateral disc edema. This was the field picture, bilateral markedly constructed field. And this was the MRI. You can see the tortuous optic nerve and enlarged optic nerve sheath suggestive of idiopathic intracranial hypertension. This is the MRI, again the MRI picture of the same patient showing the partially empty cella and the enlarged optic nerve sheath. This picture is after the VP shunt was done, and this was after the field picture after the shunt was done. So when properly intervened, we will be able to save the vision of the patient. So when we have no other cause of bilateral disc edema, we should think of some drugs causing bilateral disc edema. These are the drugs causing bilateral disc edema: vitamin A, tetracycline, steroids, NSAIDs, cyclosporine, OCP, and even obstructive sleep apnea. So the follow-up of these patients are with perimetry every year and OCT every year. OCT can pick up progressive ganglion cell loss in these patients every year. So to conclude, bilateral disc swelling, true disc swelling is a medical emergency. Persistent disc edema of any cause can cause permanent damage to the optic nerve. So prompt diagnosis and timely intervention is crucial in salvaging the vision and the life of the patient. Thank you.